From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello, and welcome to our listeners around the world. You're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. I'm Ilana Richman, an assistant editor and web editor at JAMA Internal Medicine, and I'm joined today by Dr. Vineet Ahuja, who's a professor of gastroenterology at the All India Institute of Medical Sciences in New Delhi, India, and by Dr. Michael Woodworth, who's an associate professor of medicine and an infectious diseases specialist at the Emory University School of Medicine. Welcome to you both.
Thank you, Ilana. It's a pleasure to be on this podcast.
Thank you. Great to be with you.
In this week's issue of JAMA Internal Medicine, we feature a clinical trial by Dr. Ahuja and colleagues that tests whether fecal microbiota transplant can reduce colonization with multidrug-resistant organisms in patients with gastrointestinal diseases. Gut colonization with multidrug-resistant organisms is an important risk factor for subsequent infection. And so addressing colonization may reduce the risk of future infections or recurrent infection among people at risk. So this is an important question, one we're excited to feature in JAMA Internal Medicine. For listeners who are interested, you can find a link to the paper in the episode's description. So to begin our conversation, I want to turn to Dr. Ahuja. Multidrug-resistant organisms are, of course, a really important public health concern. And there are a lot of strategies that have been attempted and discussed and deployed for dealing with both the prevalence and also the impact of these organisms. So tell us, how did you get interested in fecal microbiota transplantation as a potential approach? What led you to this research question?
We have been interested in fecal microbiota transplantation for inflammatory bowel disease. The reason being, we feel that it offers a physiological way of treating inflammatory bowel disease. Secondly, possibly it can be a low-cost therapy for a country like India, where often resources are limited in terms of going in for high-end biologicals. So a few years back, 3 years back, we published a trial on fecal microbiota transplantation along with change in diet in patients with ulcerative colitis, a randomized controlled trial over a span of 1 year, and showed that it had very good benefit. So obviously that led on to the next question, that MDRO, multidrug-resistant organisms, they obviously pose a significant challenge for infection control in GI diseases. And if colonization resistance, which is a key function to maintain homeostasis, if that can be re-established by putting in healthy microbiota, would that be a way by which we can treat MDR? We thought, let's have a large randomized controlled trial, which is rigorously controlled with the help of a double-blinded sham arm, and see whether it provides any clinical benefit or in terms of benefit in terms of decolonization of MDRO or depletion of AMRG. So that was the whole basis for doing it.
You brought up one of the interesting features of the design of your study, which was the use of a sham control. And of course, anytime we're conducting trials, if we're able to include a placebo or a sham, it can really strengthen the rigor and interpretability of the results. But the choice is, I think, interesting in this context because the outcome, which is reduction or the prevalence of multidrug-resistant organisms, is really not affected by the subjective experience of the patient. In contrast to, say, a trial where we're measuring pain or other subjective symptoms. So talk to us a little bit about how you decided whether to include a sham as being an important feature of the trial and how you selected this particular approach.
While doing fecal microbiota transplantation, there can be some interesting priming features. One of the features possibly to increase the efficiency of fecal microbiota transplantation can be a bowel lavage before the procedure. That with a polyethylene glycol, if you give a bowel wash, possibly that helps in better engraftment. Now the question is that if you're going to give bowel lavage, you won't know whether it is because of the lavage or it is because of fecal microbiota transplantation. So obviously you need a sham arm out there where you are only going to do lavage and then look whether When you did lavage along with FMT, did it transform into better outcomes, or the outcomes were same in both the arms? So this is the reason why we did a sham controlled arm. Suppose we did not have any placebo arm at all. We would have been very happy with the results, because with a 30% decolonization rate, we would have been jumping with joy and would have been thinking that, oh, this is an amazing therapy. It works so well, so less side effects, and possibly the cost is also low. But obviously, the moment you put a placebo or a sham arm out there, you realize that, okay, your enthusiasm immediately dampens down. Like science has to go through lot many curves and all. It's not easy to get a great result in science. Failure is the stepping stone to success in science, I can say. That's what these trials teach you.
That's, I think, a great segue into walking through the results. So in both arms of the trial, there was a reduction in multidrug-resistant organisms by about 30% or so. Tell us your interpretation of that. Like, do you think it's because there's, in general, a reestablishment of the normal microbiome regardless of what we do? Is there something specific about the lavage that is helpful? How can we put that result in context, and what does it teach us?
The silver lining, or the interesting part, was that there was enrichment of microbiome in the FMT arm. The diversity was better, the richness was better, and there were specific bacteria which got enriched, which possibly have a kind of anti-inflammatory effect, or which would possibly can produce short-chain fatty acids. So the question was, is it that one session of FMT was too less? Were we too conservative in terms of giving just one session of FMT? Is it possible that we could adjust for factors like antibiotic priming? We could have done antibiotic priming before the study. Is it possible that we could have had higher engraftment rates if we had done the donor and the recipient pairing in terms of their complementarity? Is it possible that if we had an anaerobic preparation of FMT, the results would have been better? So there are 3 or 4 factors which can be improved upon, and possibly if one works on those factors in terms of giving a more comprehensive FMT schedule, the results of MDR decolonization may also improve. At the same time, there is a change in gut bacteria, which is very encouraging.
So two things we learned from the results. One, that there was really no difference in colonization with multidrug-resistant organisms between the intervention arm and the sham arm, but we did see kind of important and promising changes in the organisms that appeared in the arm of the intervention.
Yeah, and another point, if you would like me to add, is that important thing is that you realize that the intervention was safe. These are patients who were admitted in intensive care unit. They were discharged from there, and the adverse effects were not so much different. So in this trial, we were hesitant in giving the second FMT session, because in early stages of while treating with FMT, you are hesitant. Would it lead to more AMR or something like that? No, it did not. So the next trial can be whether you give 2 or 3 sessions of FMT, you raise the bar, and does it help? Second point, it is for a specific population. These are patients with GI diseases, where there is already gut inflammation, where the gut may have a different kind of milieu altogether. It's possible that the dysbiosis is much more out there, and they may be resistant to this kind of therapy initially and may require more sessions. So it is not generalizable for all kind of patient groups. This conclusion is specific for one patient group, that is GI diseases, and that also patients with cirrhosis or patients with pancreatitis who may have lot more dysbiosis compared to the patients.
I want to bring Dr. Woodward into the conversation. So in your commentary, you reflect on the broader landscape of fecal microbiota transplantation as a treatment for drug-resistant organisms, and talk particularly about the case of C. difficile, which has been, I think, a real success story in using fecal microbiota transplantation as a treatment. Tell us about what's known from that work and why the successes with C. difficile may or may not translate to all other contexts.
Yeah, it's such an important point to focus on, and really the genesis of why we even think about microbiota therapies for this problem to begin with. There's been an explosion of work over the last 10, 15 years or so that's really demonstrated that for recurrent C. difficile infection, we should really be considering microbiota therapies for everyone. Access and cost and feasibility and logistics in our country, in the United States, remains a primary barrier to this. But there are data that suggests in some studies that up to 90% of patients with recurrent C. difficile infection will have a cure of that problem with a microbiota therapy. And this is why we now have 2 FDA-approved microbiota therapies that were both approved in 2022 and in 2023, although their uptake still kind of remains to be seen. We've learned from secondary analyses of patients with recurrent C. difficile infection who also were observed to have a very high prevalence of colonization with multidrug-resistant organisms, as well as a very high burden of antimicrobial resistance determinants that you can measure without culture-based methods, that patients with recurrent C. difficile infection and with multidrug-resistant organism colonization, when they are treated with a microbiota therapy, frequently have a reduction in colonization. And so this has been a lot of the original motivation for why we look at this treatment in general. What remains to be seen, though, is still how best to translate these findings into other populations and in patients who just have MDRO colonization without recurrent C. difficile infection. And although it was a clearer win, and I think in many ways a much easier path for recurrent C. difficile infection, it appears that for most patients with this problem, most donor microbiota will prevent recurrence. But we, in many ways, sort of leapfrogged ahead of a lot of the underlying work that was needed to be done to better understand dosing and recipient conditioning, as well as the necessary biomarkers to best select patients who would benefit from these products. And this is actually one of the main reasons that was cited in the SEER-109 clinical trial, and that was a phase 2 study, where SEER-109 was being developed by Seres and ultimately was approved by the FDA as the first oral microbiota product in the United States. But their phase 2 clinical trial did not meet its primary endpoint. And they did secondary analyses and found that dosing was a key reason for inadequate response. They accounted for these issues in their design of the phase 3 clinical trial. And when they met their endpoint in the phase 3 trial, those data ultimately supported approval of that product. So there's so much to know that we can't answer with animal models. And in my opinion, we need not just 1 or 2 clinical trials to answer these questions. We need dozens of clinical trials really to get at the complexity that underlies this deceptively complex treatment.
I'm going to return to Dr. Ahuja for a moment. So it sounds like there are a number of different variables that one could consider going forward: donor characteristics, recipient characteristics, dosing, preconditioning, all these factors. What do you see as the next big question for you and your team or others in the field to tackle?
This is the largest RCT on this subject, which shows that one session of FMT does not cause decolonization but changes microbiome for the better. So in other words, it provides a more nuanced understanding of the challenges as well as potential mechanisms when you use FMT for this indication. So clearly it tells us that if you design a more compact trial where the donor and the recipient pairing is important, where the number of sessions of fecal microbiota transplantation are important, where antibiotic priming possibly plays a role, and if you include, along with bowel lavage, if you include all these 4 factors, then possibly one should run a trial where not only one is looking at MDR or decolonization, but also looking at whether it leads to a lesser clinical infection also or not. Does it lead to a better clinical outcome also? Not only a microbiological outcome, but also a better clinical outcome.
Well, I want to thank you both for taking us deeper into this really fascinating area. I think it's one where we've learned a great deal from a trial that perhaps didn't have the outcome that the investigators were hoping for, but the design and secondary outcomes leave so much for others to build on and learn from. So we're really grateful for the opportunity to talk about this work. I'm Dr. Ilana Richman. I've been speaking with Dr. Vineet Ahuja and Dr. Michael Woodworth about fecal microbiota transplantation as a strategy to reduce colonization with multidrug-resistant organisms. You can find all the papers we discussed and more in the show notes. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved. including those for text and data mining, AI training, and similar technologies.